So on the slides, you see Dr. McClure performing the pec stretch, and that is how it is done. I modified how I do it because when I treat women, I don't want my hand, like my wide palm and my hand almost like on their breast. I don't even want I want to avoid that all in all. And I don't want any chances of a woman saying, oh, Dr. Carter groped my breast or touched me inappropriately. So I don't put myself in that situation with women. So what I've done with the pec liner, I've modified it myself. So I come and I place my thumb over the cortical process, and now my palm is away from the breast. My hand comes like so, and notice my palm is away from the breast. So what I do is I push the cortical process. I attempt to push it posteriorly with a combination of superior. So I'm going like this. You see? And that's still putting a stretch on it. So I'm moving in this direction, posteriorly and superiorly if I can, okay? And it's still elongating. So I'm just avoiding that all in all, which is why you would see me, doing it that way. So we make modifications as we need to with our patients. Say if I'm doing a piriformis release, I had to break out my book and show this is an actual technique. I'm not trying to touch you inappropriately or anything, but this is a technique. This is a common muscle that's like involved with sciatica, but this is where my hand will be doing a sacral release and piriformis release. And they see it in the book and see that it's an actual technique, then they're like, okay. Then I document that I showed them the technique in the book, you know. So look at your patient's medical history. Do not ignore it. Look at that medical history. I'm telling you all, when they send over that patient referral, and if they send a medical history reading, don't neglect it. Read through it. What's polypharmacy? Multiple, 6 or more. That's polypharmacy. In healthcare, we're trying to reduce polypharmacy. So the popliteus muscle, we know that the popliteus is a muscle. The muscle action is knee flexion along with internal rotation. Now there's a conundrum with this muscle. We stretch this muscle with knee extension and internal rotation. But the reasons why we likely stretch it with internal rotation is due to it having attachments at the fibula head. So due to it having attachments at the fibula head, based on Stanley Paris et al., we're gonna stretch it with knee extension and tibial internal rotation, okay? And we know it as the muscle that unlocks the knee. How does it unlock the knee? From wet position to wet position. There you go. So from terminal knee extension to the initiation of knee flexion. So we know that that could be a problem. We can have somebody to come and present and say, okay, when my knee is fully extended, I'm having a difficult time initiating knee flexion. Then we can look at that muscle as a potential muscle that could be tight. All right. And so tabian is, I have his knee extended. All right. I'm going to use my stabilizer hand to stabilize his femur, his distal femur. Why? Because I don't want the femur to follow internal rotation. Why don't I want the femur to follow internal rotation? Because then I don't get an effective stretch on the popliteus muscle. So now I got to stabilize the femur and prevent it from going into internal rotation while I internally rotate the tibia to get a stretch on the popliteus muscle. Then I can back up off of that. Okay. I could try to take them further. I could do 10-second stretches, 15-second stretches, 30-second stretches. All right, the less the duration of the stretch, the more reps I would probably do. So say if I did 10-second stretches, I'll probably do 10 reps. If I did 15-second stretches, I'll probably do maybe 6 to 8 reps. If I do 30-second stretches, I'll probably do like 4 to 5 reps. Okay, all right. But I have to stabilize the femur so that the femur doesn't internally rotate as well. I only want to internally rotate the tibia with the knee in extension. All right, so we know that it flexes and it internally rotates. All right, we got the manual technique for stretching it, right? So now, what can I have the person to do? Like, what type of closed chain activity can I have the person to do? Now, this is where you had to rationale it out. So what you saying, get them stand on one foot and rotate their upper body on that? I would add, so he's doing a dynamic stretching of it. The person is standing on one leg, right? And rotating the femur, in a sense, on the tibia, okay? So when you rotate the femur, when you rotate the femur internally, right, what is that doing to the popliteal muscle? So when you internally, it's elongating, okay? And then when you external, it's doing what? All right, all right. So we just going hypothetically off of the common insertion or attachment according to Stanley Paris. Now something else you could do, single limb stance and single limb squats, with emphasis being on what? Knee flexion, right? Because it has to unlock going into flexion, right? And so you can focus on going into flexion, nice and slow, and then coming back up into extension. You know, you can repeat those, but the emphasis in that one is gonna be on the flexion because it has to unlock going into flexion. All right, we come here like so. I'm really gonna relax. So I can get in between the septum, the lateral head of the triceps, and the lateral head of the biceps. I can get in between that septum, right? And I can come across and I can do some transverse manipulation, muscle bending, right? So I can apply the same thing that I've learned at the hamstrings and quads and gastro. I can apply the same thing to the triceps, right? Because I got a good septum right here that I can get in between and do transverse manipulation, right? All right. Now, say again.
What's the difference between prone and supine?
So prone, I got better access to the triceps. And I got better access to the septum to get my thinner and hypothenor eminence in between the septum, push up on the muscle, and transverse manipulation and bending. You feel that? Mm-hmm. All right. Now, I also have a technique that I can do. Y'all remember strain, counter strain?
Yes.
What is strain, counter strain?
Counter strain, you do it while it's doing the motion that wants to do. And strain is when you do the opposite.
Yes. So now, I can find the area of pain or the area of tenderness or the area of tautness if it's taut. So I'm just going to hypothetically go right here and apply pressure right here. You feel that pressure? As I apply that pressure, I'm moving her into extension. That's strain, counter strain. I'm moving her into the movement that the muscle makes while I keep my inhibitor and pressure on that, wherever that spot is. You see? So that's strain, counter strain. All right. So if you look that up in your book on the strain, counter strain, you will see that. So the major difference is with the short head, I'm gonna take my thumb and I'm gonna come around and locate her core process, right? And my thumb is gonna be on her core process, all right? I'm gonna bring her to slight coronal abduction, scoot towards towards me. Okay. And so with my thumb on her core process, what I'm gonna do, I have her elbow flex, right? And her forearm is at neutral right now. So what I'm gonna do, I'm gonna extend the elbow. GH joint is at external rotation. I extend her elbow. This lengthens her short head of the biceps, right? So what I'm feeling for is to see if her core process moves into my thumb. Now, to stretch that even more, what can I do with the forearm? I'm gonna pronate the forearm, because remember the biceps is, ooh. Now as I pronate her forearm, guess what's happening? This core process is moving to her thumb. She should be able to feel it. And I saw her facial expression, she felt it. So she felt the greater stretch. So now, this is how I know that I'm stretching the short head of the biceps brachii. The main thing to remember is my thumb is on her core process, all right? So I got the arm at about 80 degrees of coronal abduction. I extend, she's extended at the shoulder and extended at the elbow. Then I add pronation of the forearm. And every time I add pronation of the forearm, I feel her core process moving to my thumb. Okay? So that lets me know it's tight. She can use some stretching of the biceps, brachii short head.
Is it the core process going to
So it's your core process moving anteriorly into my hand, because that's what it's gonna do if the biceps brachii is tight. And sometimes it can even move into my hand just by taking the patient, having the shoulder extension is already there, and sometimes just by taking the elbow into extension, it can move into the thumb prematurely before even pronating, if it's super tight. Now the only difference between stretching, the major difference between stretching, now the GH joint maintains its an external rotation. So now the only thing that changes majorly is my hand placement. Now my hand goes along the joint line. So my web space now is going along the joint line, and my thumb is no longer on the core process. Does that make sense? Make sure the GH joint is maintained in external rotation. Extend it. Now extend the elbow, and now pronate the forearm. Trying to maintain GH joint. I'm trying to maintain GH joint external rotation and just purely pronate the forearm. Posterior tibialis, tendon stretch. So now, this is a good one to review. So you get the patient and knee flex and prone with the knee flexed about 90 degrees. All right. So you're gonna see me evert by just moving it towards me, all right? I'm everting, and then, yeah, there we go. So that's eversion. Now, this is how I do it. I'm gonna take my thumb. This is when I was working with Liz with. Take my thumb, I place my thumb on the navicular bone, the plantar aspect of the navicular bone. And my other fingers are just lined across the metatarsals. And then I apply a force into dorsiflexion. So I'm applying a dorsal force. All right? And I can hold that. Do you feel that? So depending on how tight the patient is, and I can compare both sides if I think that this is a problem. But depending on how tight or extensible the patient is, depending on how much they feel the stretch. Okay. So again, real foot, eversion. I take my thumb and place it over the plantar aspect of the navicular bone, and I just lie my fingers down over the metatarsals and apply a dorsal force to the navicular bones and utilizing the remainder of my fingers to move the foot into the talocrural joint into dorsiflexion. But that's the assessment. You compare both sides and treat it.
Okay? Let's just stick with that. Decreased subtalar or rear foot eversion. So if we think through the gait cycle, let's think through this with tabium. At initial contact, where should mine, does anybody remember where your subtalar rear foot should be? Okay? And then what happens is I move into, okay? Alright? Which is a component of what? Right, so we're supinated. So we've got inversion, which is a component of supination at initial contact, and then as we transition to mid-stance, I heard we get eversion, which is a component of what? Pronation of rear foot pronation. We know the midfoot follows. Okay? So this person is lacking rear foot eversion or subtalar eversion at mid-stance, let's say.
Rear foot. So they have decreased eversion.
Decreased eversion, okay? Subtalar or rear foot eversion. You could see it. You could see it subtalar. You could see it rear foot. You could probably see it also. You could probably also see calcaneal.
You said during main stance?
That's when we might functionally see that, right? Or where we need it. And if we were lacking it, it could be a functional problem. So you can see that.
Alright, I'm doing the tibialis posterior stretch. I'm going to bend my patient's leg to 90. Find the navicular. I'm allowing the rest of my fingers to go across the metatarsals. Just applying the stretch there. Probably hold this for about 10 seconds. How does this feel? This? You feel the stretch? She may not be tight there.
It may not be tight. If they're not, make sure you've got the eversion, make sure you've got the dorsiflexion and all your thing, and if they don't feel it, it may not be tight.
I'm trying to do a component motion. Well, I need my patient's calcaneus to evert. So I'm going to perform a lateral glide, moving the calcaneus on the tables.
Right? So Tavian reminded us it's a 2-to-1 ratio, okay? And sometimes we do this as an arc. If we wanted gravity to assist us, what could we have her do? So you could use a TheraBand to concentrically work your everters, which are going to do what effect is that going to have on the tibialis posterior? If you use resistance to resist eversion, active eversion, okay, what is that going to do to the tibialis posterior? Okay, right? Yeah, it's going to lengthen. It's going to work through. It's going to elongate. Okay, so you're going to strengthen that in an eccentric manner. So that makes sense. Okay, so you could do that. Right, that's the motion we're lacking. It makes a lot of sense to strengthen that direction. I would be cautious with where you have your band. Okay, it's particular. It's going to come on down. It'll actually even come across and insert down here. But the navicular and the metatarsals. But so the belly of that muscle is going to be medial, okay, and just anterior to the gastroc. So I can come in here and I will find tibialis posterior muscle belly, and I'll feel for trigger points. Then I could do any of those techniques that we've learned. I could put inhibited pressure. Okay? I could do a strumming longitudinally along parallel to the muscle belly fibers. I could do a cross or a transverse strumming across the muscle belly if I found some taut bands. So when she presses up on her toes, what should happen at the rear foot? What would we expect the calcaneus to do? Supinating. So what is it? So that component, so what are the components of the supination here? So we're gonna see plantar flexion and inversion, right? So that calcaneus is gonna invert as she presses up, and then as she comes down, we're gonna get eccentric,
Oh, yeah, I forgot.
okay? So that's another good one, okay? You could also think just gait. You could just think gait, right? We talked about this as a problem with gait. What if you just did some gait?
I'm gonna do the outer goal of the radius on the ulna to increase the extensibility of the wrist flexors. So I'm gonna grasp his hand. I kind of like it better in English. Okay. Watch his hand. You're doing it right. Okay, great. And then we want to improve wrist extension. So I think
So why don't you do that first technique?
to increase the extensibility of his wrist flexors.
So you're elongating or increasing the extensibility of the anti-osseous connective tissue between the radius and the ulna,
Okay.
which can indirectly
Do a volar glide of the proximal carpals on the distal ulna and radial. Okay, so I'm gonna stabilize his radius and ulna, grasp his proximal carpals, pull down, or like pull it away from the radius and ulna, and then apply a volar force. Oh, oh no.
And why did you choose to do that technique?
Because it's vex concave, so, or the proximal carpals are vex moving on a concave distal radius ulna.
Okay. And that's necessary for what?
It's necessary for wrist extension.
There we go. That's what you want to
Oh.
verbalize it all the way out.
Okay. And then I could have him just do dumbbell. And this would eccentrically lengthen and strengthen the wrist flexors, which could be tight, prohibiting him extending the extending the wrist.
Good job.
And then I could regress by taking this away, and then progress by giving him heavier weight. Okay.
I could do a close chain.
Close chain, I could do. You place both hands on the front knees.
So he's leaning on both hands and weight shifting.
Forward and backwards, or
Sideways, like
sideways. Okay.
Now he can shift weight. He can lateral shift, or he can shift forward and backward as well. To increase more wrist extension, he can shift forward.
It's just another term for that position, so if you hear that term, you'll know what it means.
Modified plantar grade. So, now, say I wanna increase the extensibility of his wrist flexors using muscle energy techniques. I can use post-isometric relaxation. This is called PIR, post-isometric relaxation. You can go back and read this in Dutton, all right? So Dutton has muscle energy techniques, a section on muscle energy techniques. So one form is post-isometric relaxation. So what does that mean? I contract the muscle isometrically. Then after the muscle has contracted isometrically, it is more readily to go more readily to be stretched or lengthened. So I would bring him into some flexion, all right? Hold this, hold, relax. What muscle group have I just fired? The wrist flexors, right? I just fired the wrist flexors. This is called post-isometric relaxation. So now that I have fired these isometrically, now they're more readily to be stretched. So now I lengthen them and stretch them. And then I can hold it there for probably about 30 seconds. It's similar to PNF hold relax technique. It's just somebody gave it a different name. It's pretty much the same thing as PNF hold relax technique. All right. Now we have so that's post isometric relaxation, right? Now we can do inhibited. This is called inhibited relaxation. So we want to inhibit the wrist flexors. So how do I inhibit the wrist flexors? I take them into wrist extension. I have them to hold it. Hold, 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 and relax. What have I fired? The wrist extensors. In turn, that relaxes the wrist flexors. They have become inhibited because I've contracted and fired the wrist extensors. Does that make sense? So now I can fire the wrist extensors, and now I fired the wrist extensors, the wrist flexors have been inhibited. Now I can stretch them even more. That's the IR, inhibitive relaxation. IR technique of muscle energy technique. So there are two ways you can approach muscle energy techniques. You could do post isometric relaxation, or you could do inhibitive relaxation. Does that make sense? Now go back and read that in Dutton after I just introduced this, because you could do muscle energy techniques anywhere throughout the body. All right? I can come back and say, okay, I want to do post isometric relaxation of the subscapularis, right? So I can come right here, right? So post isometric relaxation of the subscapularis. That means I'm going to contract the subscapularis. I want it to contract isometrically, right? So what am I going to do? I'm going to say, hold this position and don't let me move you. I'm trying to move him into external rotation. What muscle is firing? Subscap is firing. Now he's relaxed. Now I stretch the subscap by taking him to more external rotation. What technique was that? That was PIR. Now I could turn around and do IR, inhibited relaxation. Now hold this position, don't let me move you. Which muscles are firing? Because I'm trying to push him into internal rotation. So infraspinatus is firing, teres minor is firing, the external rotators are firing, right? Subscapularis is supposed to be relaxing. Now I can take it and stretch it. You see? So once you learn the idea and the concept of muscle energy techniques, you can use that as manual therapy as well. The muscle energy techniques are described in the manual therapy section. So now, you got muscle energy techniques, you got strain, counter strain, and you got like release, manual therapy release techniques that you can actually do with your hand. Muscle bending, strumming, stroking. I mean, you got a handful of things in your orthopedic manual therapy toolbox now. You see, you just got to know when you want to use it, how you want to use it, et cetera, et cetera.